Let me just start very rapidly. I'm Tamara Giles-Vernick from Institut Pasteur, and I'd like to thank everyone for joining us for our first Sonar-Global webinar. I can see from the list that some of you have gotten up really early this morning, and some of you are up a bit later. So let me thank you all for being part of this event. We have 4 speakers today: David Napier from University College London, Annie Wilkinson from Institute for Development Studies, David Mafigiri, who's from Makerere University, but is actually heroically calling in from Juba, and Danny de Vries from Amsterdam Institute of Global Health and Development. Just in terms of logistics here, we're going to go through 4 of the presentations, which will be 10 minutes long. I will keep you to that 10 minutes. And for those of you who would like to ask questions or make comments following the presentations, you can raise your hand or write in comments. And I will try to keep track of them all, but we have a number of people here, so we'll do the best we can. The webinar will be recorded, just to let you know. Now, before we start with our speakers, I want to just say a few words. First of all, about what Sonar-Global is, for those of you who don't know what it is. It's a European Commission funded project that's been tasked with creating a global social sciences network for the preparedness and response to epidemics in AMR. And we always felt that it was really important to sort of concretize a network, not to be just sort of an inert entity online. And so one of the ways that we do that is through the development, adaptation, and testing of tools and models addressing vulnerabilities as they're understood and experienced on the ground and in specific contexts. So this is a really important priority of Sonar-Global, and we see that identification of locally meaningful categories of vulnerability as an initial step in multi-scalar, multi-sectoral engagement. So this is an especially important question in the COVID-19 pandemic, which is affecting the world's populations in highly differentiated ways. In April, as many of you know, The Lancet published an editorial that concluded a one-size-fits-all model, that is to COVID-19, will not be appropriate. Each country must continually assess which members of society are vulnerable to fairly support those at the highest risk. So as social scientists, we're not just talking about those at the highest epidemiological risk. What preoccupies us within Sonar-Global are the ways in which COVID-19 is producing inequalities and vulnerabilities in both expected and unexpected ways. Vulnerabilities for us is multidimensional, unevenly expressed and felt and situational. So the presentations today will reflect on how it is that we can understand and evaluate vulnerability, how vulnerability is manifested, where, why, with whom, what consequences. But I also hope that the presentations and the discussions will produce some reflections about what can be done to address these vulnerabilities and to promote resilience. So with that, I want to put myself on mute and ask David Napier to speak to us. And I would just request for those of you who are here just to put yourselves on mute if you're not speaking. Okay.
Great. Tamara, shall I begin? So first of all, I'd like to thank you all for the time that you've provided us this afternoon. I only have 10 minutes, so I'm going to leap right in. But before I describe what a vulnerability assessment is and what we are doing, there are a couple of critical points that I want to make to set the stage. The first is that we assume that in times of crisis that inequalities get exaggerated. In other words, in COVID-19, we have a perfect case in point where in the absence of going into the field, most don't even have the slightest idea of what's happening to the most vulnerable populations. read or use the internet. So this is, I think, a dramatic example of something that we possibly don't like to think about at community levels, but we assume that this is the consequence of exaggeration of inequalities that were there already, but that have pushed people beyond the capability and opportunity threshold. The second point is that because of this, the vulnerability assessment is not just a way of identifying categories of people we already know are vulnerable and finding out what's going on in their lives, but more importantly, it's a structured way of assessing the dynamics of vulnerability in a local context. And also, and this is critically important, a way of identifying what we call new case definitions of vulnerability that emerge locally within the context of a health crisis, as we now see, say, in COVID-19, where nobody was really thinking about the vulnerability of people in shared accommodation, wealthy or poor, indeed, especially those already in, as it were, care, as we call it, or employed single parents, say, without secure employment and health benefits who had a job. Instead of focusing simply on the elderly or those with pre-existing conditions and the ones who we know are vulnerable. Joy, could you go back to that slide, please? Thank you. So one strategic point that needs to be emphasized right away is because of COVID-19, clearly we need to acknowledge the significant obstacles present to engaging in any kind of an assessment. And indeed, we realized as we were conducting our vulnerability assessment in the field in Uganda in February, which Mafigiri will talk about soon, we're probably the only people who have systematic field data on vulnerability for COVID-19 anywhere globally, thanks to the hard work of David and his team. So with only my 8 minutes left, allow me to jump into this first slide, which shows the structure of the vulnerability assessment. And remember, these aren't just inventories of questions to ask, but they're actually ways of trying to understand in a structured way the dynamics of vulnerability in its local context. And of course, in order to do that, you need to ask a number of closed and open questions about the formal sector, service domain, utilization patterns, the sorts of things that public health people do regularly. But you also need to then drill down to local levels, especially if you're going to be involved in any kind of community engagement activity, and try to understand what community structures are at work, how do they adapt in times of crisis, are the adaptations functional or dysfunctional, which they sometimes are. In other words, how do you identify any scalable local activity that in the absence of formal sector provision makes things better and potentially helps people to live, enhance their well-being and to live more productive lives. Now, this is all standard government community engagement kind of framework activity that obviously lots of NGOs are engaged in at the level of community engagement. But the point is, because of the emerging inequalities, we need to go beyond that. So when we do a vulnerability assessment, we take the categories, the known categories, we try to find out new case definitions, and we also ask people who emerge as vulnerable if they can lead us to people who are more vulnerable than they are, who do not have the behavior change capability, opportunity, or motivation to present themselves and to represent what it is, or what the barriers are that keep them from going across that threshold from being simple calamity coping, in which COVID-19 might be number 10 on their list, to being able to engage in productive health behavior. Now, you can give me the next slide, just to point out how dramatic this problem is. If we go to the next slide, you can see that I didn't want to use an example from the so-called vulnerabilities of people, the standard ones. This is from Katrina. This is the United States. Please don't loot, it's all we have left, God bless. All right, now you can see here that the concept of community, as we would otherwise define it, is really highly challenged. And this is not exceptional, as anybody who's worked in an extreme hardship situation, whether it's natural disaster, war, or infectious disease outbreak, knows that these are serious realities that need to be addressed. So if you can go to the next slide, I will describe to you a little bit what we mean by a case definition. Clearly, just as a note, I was on a call a couple of days ago where some of our Chinese colleagues were attempting to develop a study, a randomized control study for conducting a trial on the efficacy of mask wearing versus hand washing. Of course, this is completely impossible. It's completely impossible in real time. And the reason it is because, as everyone is aware, that these risk factors are compounding. You cannot take them in isolation. So for COVID-19, we can come up with biological, social, geographic, and cultural factors, and you can modify this list as you wish. But if you hit the advance button, Joy or Carolyn, whoever's running this, you can tie this together, go across again, and again. You can tie this together any way you want. You can go up and down these columns to develop a more complex case definition that you can get through doing field work, and that these are codable. So the idea here is that we're not just giving a ethnographic example, which somebody would accuse us of exaggerating local conditions simply by isolating one example and saying that this is what vulnerability is like in a certain place, but we're trying to come up with measurable definitions that are also scalable. So in the 1 or 2 minutes that I've left, if you could just go to the next slide, I will conclude by saying that clearly our idea is not only to assess the dynamics of vulnerability in a local context and to come up with case definitions of vulnerability, but finally, the second goal is to extrapolate those findings and, as we say in Sonar-Global, to map, share, and act. That is to say, to map the scaling of those case definitions to wider populations, to share the scaling of local findings to regional and to national, and indeed even global understanding, and to act, that is to say, scaling that research into specific actions, and to use limited resources more effectively. So with that, I think I'll stop and move on to our next speaker. Thank you very much.
Thank you very much, David. We have Annie Wilkinson from IDS next. Annie, I don't know if you have a camera, but if you can put yourself on camera, that'd be great.
Is that working? I can't tell. Anyway, I have put it on, so hopefully you can see me. Okay, yes, so I'm going to talk about vulnerability in informal urban settlements. This is building on lots of the ideas about vulnerability from Sonar-Global and David, and some very helpful contributions from him. Also a briefing that I did for the Social Science and Humanitarian Action Platform, which had contributions from, I can't remember how many people, but lots of different people from working in informal settlements and activism and policy all over the world. And then also a research program, ARISE, that we're involved in, that works in Bangladesh, Kenya, Sierra Leone, and India. Okay, next slide. So yeah, first of all, I think just why informal settlements? And one thing is to just recognize people that don't work in this field don't always realize how big an issue this is. So there's nearly 1 billion people that live in so-called slums or informal urban settlements around the world, mostly in low and middle income countries. And in some low and middle income cities, you know, it's up to 30 or 70% of the kind of city populations are classified as informal. This has been the result of rapid and unplanned urbanization, which is increasing. So the percentage of informal to formal settlements around the world is growing, as is our urban populations. And I think the implications for health and for epidemic disease of all of this rapid unplanned urbanization hasn't really been kind of thought through that much, to at least beyond kind of some stereotypical or sweeping generalizations about kind of cities being vectors of disease. But in terms of vulnerability, yeah, it's generally agreed that these informal settlements are vulnerable settings, and that's really been highlighted with COVID-19. So all the kind of advice about washing hands and social distancing is just impossible in some of these settings. But what I think we should kind of note, and what's interesting here is that we often think about vulnerability in terms of maybe people and social relations and things like that. But here, thinking about informal settlements encourage us to think about the spatial dimensions to vulnerability, which are themselves a result of social processes. But I just wanted to kind of run through some of the very specific things about informal settlements. So first of all, that the key thing is they're characterized by a lack of formal recognition. So governments often don't want to admit that they're there, ignore that they're there, deem them to be illegal, Housing tenure in these places is often insecure, so there's kind of threat of evictions. That's this disincentive to kind of an unwillingness by governments to provide services, and a disincentive for residents to kind of do their own upgrades. Often that's they are often kind of characterized by high population density, not always, but sometimes. With this kind of unplanned and rapid growth comes kind of inadequate infrastructure. So yeah, housing, water, sanitation is typically all, you know, poor quality and unaffordable or inaccessible. The land is often unsuitable and dangerous and brings with it a whole load of other risks too. So the picture I've got here is in Sierra Leone, where the land is kind of reclaimed from, land is being reclaimed from the sea, built out of trash. There's other places that is kind of up on hill, precarious hills. And then the other really big thing about this is just the lack of data. So urban and rural, there's often not good disaggregation between urban and rural data, but then within urban data, these informal settlements just are kind of, not captured, often, sometimes deliberately, sometimes just the data systems are inadequate. So there's a huge amount of lack of knowledge, basically. And with that, there has been some kind of exclusionary policy making or irrelevant policy making, or just hasn't been policy making. The next slide. So this was in the briefing that I did. We kind of went through what the different dimensions of vulnerability were. Like, because this is a neighborhood geographical thing, there's a whole cross section of different forms of vulnerability. I'll race through it, but as Tamara mentioned, there's the epidemiological vulnerability, which is maybe less what we're concerned with. But I would add, for informal settlements, again, because of this lack of data, there's some real uncertainties about what those epidemiological vulnerabilities are. So particularly, for example, around NCDs and chronic conditions, typically these places have kind of poor, not particularly healthy food environments, or chronic kind of infections and all sorts of things that has actually, when people have looked, they found really high levels of kind of chronic and chronic conditions and NCDs, but we don't really know. So lots about transmission vulnerability, so density, lots of social mixing, shared households, highly mobile, combined with kind of hygiene infrastructure that is shared, so toilets and water queues and all of that, and just simply people's livelihood imperatives being more urgent than the disease threat in some cases. Very vulnerable to control measures, so kind of livelihoods, lack of kind of formal social protection that meant all the kind of social distancing measures had a really big impact on kind of people's ability to get food and to basically survive the day. And then lots of systemic and intersecting vulnerabilities, which I can't do any justice to. But whether it's kind of the gendered impacts, or kind of rising crime or tension, or kind of decimation of kind of care and social support networks, all sorts of odd things. And then I wanted to add as well, just this kind of looming long-term economic crisis, which is obviously affecting the whole world, but I think in informal settlements there is particular, it's some of these kind of issues just seem to be intensified. Next, please. And then the final major point I wanted to make was about kind of, I don't know if it's right to talk about a policy vulnerability, but I guess really what I meant was this is the risk of inappropriate policies that stem essentially from this kind of inadequate understanding and inadequate understandings of these places. So the fact that we're missing basic health, demographic and economic and social data, like how do you plan an epidemic response in that scenario if you don't know how many people live there? We don't actually really have a good idea of what the current situation is in lots of informal settlements. There's some media reports that, it's pretty bad in some places in Latin America and everything. And so how do you make those, the kind of the choices between the trade-offs between the kind of the health risks and the social and economic impacts if you don't really understand what either of those are in these places? The other thing to say was that, externally applied images of slums have, traditionally kind of depicted them as chaotic, dirty and criminal. And this is kind of informed historically repressive and violent kind of interventions in them. And that we've seen that again with COVID-19. So there was, the enforcement of these already impossible and unfeasible social distancing measures was often done with, police and army with a lot of violence. And all of this overlooks, basically the kind of realities and the kind of capacity of people in these places. Another big aspect to that, I think, is also just the extent of informality, both primarily in kind of informal economies, the kind of work that people are doing in these places, and the way that's also connected to kind of city economies is just, again, not particularly well understood. So again, the impacts of the control measures were particularly acute, and the responses to mitigate them were also, in many places, mostly kind of inadequate. So even places that did try to kind of roll out social protection schemes, whether it's kind of cash transfers or things like that, tended to not reach these more informal livelihoods and communities. And then I think there is this issue about kind of vulnerability to, COVID opportunism. There has been reports that, the clamping down, things that kind of governments have been wanting to do, whether it was evict or clamp down on street trading, COVID-19 being used as a kind of an opportunity to do all of that, which does, have much kind of, the burden is much higher on these places, and it does longer term harm. So I think there is an issue about kind of particular vulnerability of informal settlements to COVID-19 policies. Final slide. This was just because I didn't want to end on a negative note, that there is also, a lot of local capacity and organisation, and there has been really wonderful kind of levels of mutual support and organisation happening in these places, sometimes in partnership with local governments. I've seen some really brilliant stuff happening in parts in Kenya and in Freetown and in Sierra Leone, and so there's huge potential for the kind of co-production of COVID-19 responses, and I've just put a few links there to some more information about some of those. And that's me.
Thank you very much, Annie. Really appreciate it. So we have next David Mafigiri. David, are you there?
Yes, I'm here.
Fantastic. Thank you.
Yes, and I first apologize. My camera doesn't work, so I'm sorry I can't come on camera. I'm just going to give broadly, work that is ongoing, I should say, in Uganda, and we were fortunate to start some of this work just before COVID reached Uganda. Next slide. So in Uganda, generally speaking, like in other countries, faced with an emergency, the governments have employed a top-down approach in implementing the public health and social measures that include, risk communication, advocacy for social distancing, enhanced personal hygiene, lots of lockdowns, curfews, bans on transportation, and of course, including, or let me say, amidst limited laboratory COVID diagnostics or surveillance or case management, as it was an emergency. Next slide. So, what we are realizing is that a lot of governments are increasingly facing challenges, including in Uganda, where there's a lot of resistance in implementing some of those public health and social measures. And I think the problem, we see that problem more acute in low resource congested communities. Of course, like in the peri-urban areas, slums, but importantly also in border communities, around border communities. So in Uganda already there is so much disruption in the livelihoods of people, and we now know that it is particularly vulnerable populations, as some of the previous speakers have mentioned. including people in the informal sector, what you can describe as informal sector, large, small-scale agriculture, producers, of course, women, children, elderly, very importantly, the disabled. So generally, poor people living in urban and peri-urban areas. And when you add in closure of businesses and banning transportation, a lot of people have lost sources of income. And it can explain a bit of why there is some inability to cope with these new social norms that are going on. So the community coping mechanisms to these new social norms somehow appear to inhibit the uptake of measures that are proven elsewhere, that are known to be important for controlling the outbreak. Next slide. As a result, there are so many indirect consequences of this pandemic. Some of them include reported increases in mental health issues, a lot of anecdotal data so far, like popular media reports and other reports of domestic violence or interpersonal violence. But broadly speaking, you are seeing other consequences to well-being, such as where do people access water and appropriate sanitation to be able to adhere to the measures that are being implemented. Nutrition, or people who already have chronic conditions are struggling most with the consequences of the pandemic. Next slide. So the question is, what then would be the value, or would have been the value of vulnerability assessment? And I think that vulnerability assessments, as described by the earlier speakers, being more than just the individual level vulnerability. When you think of the domains that are assessed, I think it would have provided information. It should be able to provide us information to contribute to what I call here localizing the mitigation measures. So we know, like the previous speakers said that, or one of the speakers before, we are not only concerned about the well-known highest risk groups epidemiologically, but just generally overall risk. What COVID is showing us is there is, in a holistic manner, maybe overall risk, ability to be resilient to the impact, the consequences of COVID, requires understanding certain attributes of communities, of cultural settings. And we know that the way we should be conducting vulnerability assessments, we would be able to establish some long-term and predict some unintended consequences of the epidemic control decisions, so that we can also understand what kind of decisions are going to be made in the field that may inadvertently undermine the response goals. So you want to be prepared, and you feel that if you assessed vulnerability and understood the way people are likely to be impacted, you are in a better position to inform some of the programming. We know that we are examining some cultural and social factors that may inhibit control measures. In certain communities, the way there are certain social norms, greetings or eating together, or the way you behave around each other, that if you understood those well, you are in a better position to then plan for mitigation, better uptake of mitigation. So vulnerability assessments thereby should be able to inform local and economically sustainable ways to impact those communities the impact on those communities. That's a typo, sorry. And it may help us in mitigating what I am terming contextual vulnerability of health systems. The urban areas in settings like Uganda, the health system, generally speaking, would become very stretched easily by the requirement to control the COVID outbreak. Next slide. This is my last slide. So going forward, I think that we are going to need a sustainable or affordable and also accessible way of programming. And in order to do that, I feel vulnerability assessments will help to determine who has capability, someone's capability, or in video group capabilities. Which opportunities are there? And what kind of motivation to affect positive change? Positive change such as adhering or complying to some of the new social norms. So we know that over the last 2 months, there has not been so much meaningful community engagement, for instance, to facilitate individuals or households and entire communities to take charge of their health and social well-being, in part because it's an emergency. It came very fast. It's an emergency situation. However, over the 2-3 months, we feel that if people need to protect themselves and their neighbors from the impact of the impacts associated with the pandemic, we need to have the ability to engage with these communities, and that will bring their voices to the research that is being done and eventually to decision-making processes. I will stop here for now and maybe take questions at any time. Thank you for the opportunity.
I'm online, David. Sorry for joining late, I'm online.
Thank you. Thank you, David. So we're gonna just, I know that people probably have questions right now, but we're gonna pass to our last presenter, Danny de Vries, and then your questions are more than welcome.
Yes,
go ahead, Danny.
Thank you, Tamara, and thank you everybody also for letting us talk about our project here, because this is not a project necessarily related to SonarGlobal, but it is a assessment of some kind of vulnerable populations specifically in the Netherlands. It's not a comprehensive vulnerability assessment as David both Davids have talked about in the previous slides. We had about 1 week to put together this study, so we were not able in the position to first really figure out who was vulnerable in the Netherlands. So we had to actually go by our best intuition, plus also whoever was available on really short term to jump in with us. Next slide, please. So the next, I need to use my pen. So the obviously, just like in all the other countries, the Netherlands also has a policy of social distancing, and the whole goal of that is to protect the vulnerable groups in society. And we can distinguish to some extent physical vulnerability, which could be the epidemiological risk of infection, like for example people who are in poor health or over 70 years of age, and people with pre-existing chronic or severe medical conditions. But you can also look at what we call social vulnerability, and you've already seen a number of different kinds of vulnerabilities coming by the screen, I noticed, but Caroline, can you go to the next? Thank you. In the disaster literature, typically there's this distinction between physical and social vulnerability as very broad categories. And social vulnerability would then be the degree to which people are able to anticipate, cope with, resist, and recover from the impact of a stressor. Next. And so next. So stressors, of course, in this case are not just COVID, but it's also the impact of policies like the social isolation and home isolation that we've been seeing in many places in the world now. So we have a study that was funded for about 1 year, and the main question is, what are the consequences of these measures on socially vulnerable populations in the Netherlands? And the questions we're asking are really practical. What kind of problems do people run into? And these people specifically then are people from representing socially vulnerable populations or their caregivers. Do they find solutions to these problems? What other solutions can be generated, and how can policy support these solutions? Next. So the methodology is a consortium. Like I said, we had to be ready to run, so it included societal and academic partners. Next. It's a longitudinal mixed method study. The idea was to have repeated questionnaires and repeated interviews with the same people over a period of, well, in fact, it's just a half year with qualitative interviews, and then the quantitative work will go on a little longer. Next. And so the target groups that we included are older adults, among those people living alone, people with dementia, people living in nursing homes. This is all in the Netherlands. People with severe psychiatric problems, people with learning disabilities, homeless populations, young families, and people reporting domestic violence. Next. And in all of those groups, we have been talking to both professional caregivers and family members. So here is a bit of an overview. We have about 111 interviews done right now. And so we have the first results actually came out today. It's in the papers now and on the websites, etc. So it's fresh from the press, they say in Dutch. And we've been looking at mostly the most urgent problems so that we can immediately give some advice to policies. So this is based on 3 weeks of data collection. Go ahead, next. Yeah. So what we find is that for many people living independently at home, loneliness really is a pressing issue. Day programs and structures have fallen away, and face-to-face care support and initiation of new care trajectories have reduced a lot. In some cases, stopped completely. Next. Another thing that we've noted is that the idea of what's stated here, that I'm merely thinking backwards, and this was a citation of some homeless client of one professional mentioned. And it's relating to this sort of the idea that there's no future, there's a diffuse, uncertain future, and there's an absence of a meaningful day-to-day, like where are we going, and this emptiness that's there. And you also see with lots of older people that memories of past, like in the Netherlands at least, memories from World War II are coming back, where people are sort of relating to it because of the social isolation they experienced then as well. Older people are also afraid to die, and it's not so much because they fear death, it's but because they fear to be alone without the ability to say goodbye to their loved ones. And across all groups of people, you see extreme anxiety about the impact of Corona. And many of these groups that we've been studying, which include people with learning disabilities, is that they do not entirely understand what's going on, which is a big issue. And there's a lot of reporting on health problems. There's depression, self-destructive behaviors like gambling and drinking. Also mentioned this compulsive online shopping. The other thing which is interesting actually is that homeless people now seem to have gotten, at least in a country like the Netherlands, suddenly they have places where they can stay. Sometimes it's even in hotels. But on the other hand, all their day services have stopped and all their social services have stopped. And so they also are not sure what's going to happen after the hotels, after the situation is over, where they're going to go. And with that, they also don't have, with the day program stopping, they also don't have any opportunities to earn any more money. Finally, not finally, but because of home isolation, we see, okay, that's why I missed one there. One thing that's, well, the thing that was in between that's not on the slide is that we see tensions rise within families. also because of unsafe situations that then developed, and people that are typically giving social and professional service to these people have a harder time reaching them. In acute situations, people do still go. What's interesting in across a lot of groups is that we see that new trajectories for care are being put on hold. So people are now waiting a lot more. And overall, we see kind of a lack of perspective about the future. Next. So in the long-term care facilities, the results show that a large proportion of family members believe that the health of their kin is decreased relative to before the corona crisis. And the data show a clearly observed difference in effect among the residents by both kin and professionals. So people are more depression, more anxiety. Also, people with dementia, family members of those people express a lot of anxiety because of the lack of stimuli that's going on now, and they really fear that these people are being hurt very hard. And 1 out of 10 family members has not spoken with their kin in the past 4 weeks in long-term care facilities in the Netherlands, which is, I think, a lot of people. We also see that since day programs have stopped and social services are only existing at a limited capacity, that people are becoming more and more dependent on informal caregivers who are becoming overburdened. And some informal carers are struggling with the fact that they are risk group themselves, so they don't really want to give care. Or there's the extra pressure that's going on at times leads to more domestic violence. So here you see a slide. What we did, we asked what family members and healthcare professionals find more important with respect to long-term care residents. And they had to choose between either quality of life or safety. And you can see that the family members, and I think we're talking about 500 of them. No, it's 1,100 family members and 500 healthcare professionals, something like that. Family members choose quality of life over safety, while healthcare professionals have a bit of the opposite trend. But at the same time, you also see that a third of people cannot choose between the two. So what this suggests is that both quality of life and safety are equally important, and with some, different people are looking are having a different position on that scale. And in the current situation in the Netherlands, the emphasis has been on safety. So it's time to look more at quality of life. Next. So we also see that face-to-face contact is very necessary, and there's a number of situations where it really has to happen. If you can go to the next, it's getting to know new clients because you need to build trusting relationships. It's people with small or absent social support networks that really need face-to-face contact. Next. For situations with safety for clients at stake, go ahead, Caroline. For clients with psychiatric issues who are experiencing anxiety, depression. Also some administrative issues like post, banking issues. And what's also interesting is that a lot of the professionals are saying they really need to be in homes to see what the situations of these vulnerable populations really is. I mean, they can say that they're okay, but if you see letters everywhere, empty bottles, you know that there's something else going on. Go ahead. There's people without computers or laptops, and of course, then you cannot have digital communication. There's people who actually try to avoid care, and they also need a visitation. So go ahead. There's definitely reasons next to obviously domestic assistance in housekeeping and physical care. There are many other reasons to really go for face-to-face contact in this time. Go ahead, Caroline.
Danny, I'm going to ask you to wrap up.
Yeah.
Sorry, because you've gone over.
Okay.
Go ahead.
Go to the next slides, Colleen. Go to next. So we ended up with these policy recommendations. First of all, we need to broaden the goal in the Netherlands from prevention of infection to facilitating what we call essential social traffic. There's some traffic that really needs to be done. socially to ensure minimal health and quality of life. And it's particularly important for socially vulnerable populations. And the second recommendation is that we need to learn to weigh risk more in context. We need to have clear national boundaries, at the same time local solutions to deal with those. And this is really important to be able to safely reintroduce day programs specifically for the most socially vulnerable populations that we've been studying. Thank you.
Okay, thank you so much, Danny. Sorry to cut you off. Thank you to our other speakers. Just to sort of sum up very quickly, and then I want to open up the floor to people who want to ask some questions. We really hope you have questions. Is, you know, a couple of just points that I think seem to come out from all of your presentations. One is quite obviously the kind of multiple forms, expressions, domains of vulnerability, as well as and this is a point that sort of I don't know, I guess kind of grabs me, but frequently. Every single one of you, I think, stressed the importance of kind of local, bottom-up understanding of these vulnerabilities and how they express themselves, what their consequences are. And it strikes me that this is happening at a time of kind of unprecedented top-down interventions. You know, the confinement, for instance, of billions of people across the planet. And, you know, a number of you talked about policy recommendations. So I guess what my question is, on what level do you find the greatest traction, you know, in sort of getting not just the policy recommendations articulated, but actually taken up and put into practice? My guess would be perhaps on the local level, but is that the most effective? So I just wonder if each of you, if you like, if you're moved to respond to that, to, you know, talking about how that translation of policy recommendation into practice and where that we can sort of get the most effective response. I'm going to mute myself. I don't know if there's anybody who wants to ask or answer that.
Mara, I'm happy to kick off on this.
Sure, go ahead. And then I see a question, and so go ahead.
I'll just keep this very brief. I think that that you've hit one of the extremely important points, the nail on the head, because clearly the vulnerabilities, if we're going to address them, and I think this came out in all the presentations, Danny's very concrete work, David's and Annie's, both of their presentations as well, is that because vulnerabilities are unique and emerge uniquely, that doesn't mean that we can't compare one country to another or one city to another. What happens is that local leaders become much more aware. I mean, mayors have to face their populations every day of the week, so they tend to be quite aware of local challenges, which is why C40, the World Organization of Mayors Addressing Climate Change, and by the way, now health, have emerged as being a very, very powerful voice. And this gets to Annie's point about governments themselves being quite vulnerable. I think that this is a real challenge in COVID-19 because it does indicate a future regionalism or localism, which is completely at odds with previously global narratives about universal health. I'll stop there, over.
Does anybody else want to respond to that? Otherwise, I see two questions.
I can say something very quickly.
Good, okay.
Yeah, I mean, I guess the first one is I agree, it has been kind of unprecedentedly, if that's a word, top down. But there's also been, I think, inevitably, just because it can never all be top down, there has been a huge amount of kind of bottom up work, and whether that's kind of mutual support on the ground, whether it's kind of, yeah, local adaptations of things, or in some cases resistance. I guess the question then is like, how much do to what extent do the top-down kind of processes allow or engage with that adaptation? Do they kind of try to repress it with violence and things, which has happened? Or, you know, do they actually start to kind of form, you know, partnerships with local organizations and civil society groups and try to kind of, yeah, do the adaptations together? And I think that the urban space has been quite interesting in this, because there, as I kind of alluded to at the end, there's so much kind of actual urban grassroots civil society development, in particular in these informal settlements, or in some places, not uniformly, and the city governments, the places where they've had good existing partnerships with city governments, we have seen some really kind of good, inspiring kind of partnerships emerging for COVID-19. But it's not uniform.
Can I add something to that, Tamara?
Go ahead.
I think you're right, Annie, that these partnerships are really interesting to look at and important. To what extent do they develop? And I'm not sure if the Netherlands is necessarily a typical case, but certainly in the Netherlands, it seems like there is definitely both bottom up and top down, and that actually, for example, the government, advised by the medical professionals or the outbreak management team, was going to not close the schools. To close the elementary schools were supposed to stay open, but it was actually pressure from society and the civic organizations that led them to close it anyway. So there's actually a lot of pushback from the bottom. And I don't necessarily have the feeling that in the Netherlands it's mainly top down and there's a lot of negotiation going on. And you can also see that at the micro level, because one thing we found is that when caregivers listen to what clients actually want, they tend to do better. They tend to have less problems with their isolation, less problems with loneliness, as opposed to those who were told what to do. So that's an interesting parallel, perhaps. Thank you.
Okay, thank you. Okay, so I have a question from Concha. I have a question from Julien after that, and I have a comment which you can certainly expand on from Dr. Kwoji Joseph Lodu. So first, Concha Martin from Medipiet. She says, thank you for these interesting presentations. In order to engage communities, we need to think about the most vulnerable people and their circumstances, to find the better way to contact them and how to engage their social environments. The main way to contact people during the lockdown times, during the pandemic, has been through devices that might be out of the, I'm just trying to scroll down. Out of the tools used by those who are most vulnerable, what are the alternatives? Local radio, local social organizations? What other means do you see? This is a question mainly addressed to the third speaker, which is David Mafigiri. David, can you hear us? Go ahead.
I hear you, but I did not. Can you just repeat the question?
So she wants to know, she said most of the main way that people get contacted during lockdown times have been through devices, which might not be, if I understand correctly, might not be used by most vulnerable people. Are there alternative ways of getting to these people? Is it through local radios, local social organizations? How do you do it when you're in lockdown?
Yeah, thank you very much. Yes, in communities where people don't have devices, here we mean smartphones or laptops maybe, but there's wide coverage over radio, but also use of different local resources or ways of transmitting information or communication. So it could be these megaphones, people moving with on a bike, a bicycle or something throughout the village communicating. Some communities have got what we call a public speaker, public administration system, where you have at a village local site, designated site, a market, a trading center, and you have this loudspeaker, you know, public administration system that they use for their other routine social lives, you know, announcing social events, be they burials or, you know, weddings or whatever it is, church ceremonies, use of religious leaders a lot. I think generally in the, what I can say is for constrained societies, digitally constrained societies, if I may use that word, I think at the same time there have been several health or humanitarian emergencies that along the way have kind of equipped these responders with an ability to try and reach people beyond use of cell phones. Now, that is very difficult during lockdown or banning transportation or banning gatherings. It's a lot harder. And that's why I think at times in the beginning, a more authoritative top-down approach seemed like it was okay. But the longer it goes on, you know it's not okay and people resist it. I'll first stop there. Over.
Okay, thank you very much, David. Julienne. Julienne, I heard that you were raising your hand.
Hello everyone. Thank you very much for sharing the experience. I'm just, I have one question and one comment. The question is addressed to the four presenters. Just I would like to know how these research results are shared with the national COVID-19 response team, so that they can take into account this result and recommendation to influence the community engagement. This is my question. And now, as a comment, I would want to say that I'm sorry to say that we still having huge challenges. All the challenges that you are raised, I have it in the field as an implementer, anthropology and risk-com implementer. And I can assure you that my team and I have evaluated all the 19 plans and national and strategic risk communication plans of 19 countries of West and Central Africa. And I can assure you that the challenge is community engagement, and top-down approach. And people are completely desperate in the field, and we're still struggling so that community engagement can become key at the central of all the interventions of the COVID-19 response. We are still assessing countries. For the moment, we have assessed 19 countries, and we'll assess the 27 of them. But the main issue is that communities have been left apart in when developing plans which are top-downs, and their community have been completely left apart, and community engagement is still challenging, and their vulnerability have not been taken into account when developing these plans and strategies at national levels. Thank you.
Thank you. Do any of the speakers want to respond to that?
I'm happy to say, I'm not sure if the Netherlands situation is very representative for what the situation you just described, but in the Netherlands, we are able to share findings directly with the outbreak management team, which was very fortunate we are, because it was also funded with that goal. And then next to that, we use media, newspapers and websites, and we register everything in databases. Community engagement in the Netherlands is, I think, rather broad and wise, I already said. So that's it for me.
Yes, thank you. This is David. I just wanted to say we are able to share findings, and we will when we complete this also, but like previously, through several ways with the governments. I think there is increasing recognition from the mostly biomedically dominated, structures that respond to public health emergencies, of the need to appreciate some of the social, anthropological, behavioral aspects. And because of that, there are avenues they use to receive information, such as incorporating social scientists on their national task forces. And so by doing so, they expect to receive data. They are able to sponsor researches where possible, and they make it part of their pillars in response, particularly to inform risk communication. So some members serve on these committees. They come to the university and seek for members, or they co-opt as they move along. They also work collaboratively between themselves as regional blocks. So I know that if the South Sudan regional bloc needed help through their partners, maybe UNICEF, maybe World Health, or any other agency, they may seek help from or advice from Uganda or Kenya, and then they get people seconded to work, on these groups, with these groups. And it includes meetings, advising during technical working groups, or outright fieldwork, designing studies and other things like that. Lastly, media. A lot of access through the media, through writing, through attending talk shows, and this kind of forum where you do get a chance to present to the attendants, who include public policy makers. Over.
Tamara, could I jump in here? I just have one quick point to make.
Sure.
I think that the first and second, the initial and second question are super interesting, but I think they have a shared takeaway lesson about contacting vulnerable populations and conveying what we learned. And that's that we have to think more about dealing with the basic inequalities that create these entirely inhumane conditions for the most vulnerable people before something like this happens, so that once a destabilizing event occurs, we actually can do it, as Danny pointed out, to assess the risk factors and understand better when it is entirely unacceptable not to contact people directly who desperately need that assistance. Over.
Thank you for that point. Okay, so we have, I know there's a long list of people and you've been waiting. So the next point or question is from Dr. Lodu. You had a couple of comments. I wanted, would you prefer that I read them out, or would you like to contribute something?
Okay, maybe you could read them out, but I think what I will say actually, when I followed on a presentation from the professor from University of Amsterdam, and especially in the research they've conducted out, focusing on the vulnerable people, especially the elderly, maybe those who are homeless. Like for us here in South Sudan, currently together with Dr. David Kawaa, we are testing actually a pilot project, which we are concluding today, and then next week we start going to the data analysis. Mostly is focusing on a community feedback mechanism in their perceptions of the disease in terms of rumors, their beliefs, and then what are their observations. But like when I learned from the research done in Amsterdam, in Netherlands, is quite interesting that also here in South Sudan, we may need to focus also into more research targeting those vulnerable people. Will be the elderly population, those who are children, the homeless, and then as well as those with comorbid condition, because we may have a lot of people with chronic illnesses, like here in the tropical region, we have HIV/AIDS. We also have got a good number of those who are living with the virus in South Sudan. So in the event of them contracting like a COVID-19, how can they be helped? How will they perceive what they will be able to get from the health structures, which in South Sudan actually are non-existent at the moment. And then also like here in South Sudan, maybe also in my view into the vulnerability, it stretches along all angles from those who are vulnerable and even those who are non-vulnerable, because people, their quality of life is being affected because access to basic needs is really being reduced. That's why even lockdown is not possible, because people can't stay at home without food, because most of them get a daily bread based on what they do daily. So in South Sudan also, like you find health professionals actually are not in the lead in the fight against the COVID-19. That's why the quality of the data going out into the public is not all that consistent with what is supposed to be done globally, according to WHO recommendation. Like you can see, I think we have already surpassed the 1,000 limit mark for COVID-19 cases, and even we expect more and more cases will still increase, and maybe even our health system will be overwhelmed. So I had actually posted a question private to David asking if still South Sudan need to be supported in more research. For me, weeks I say yes, more study need to be done, and then the various institutions in the country, the UN agencies, the national organization will be able to support in that. Thank you, over.
Thank you. Did anyone want to respond to that? Danny?
Yeah, real briefly, I really appreciate what you say and understand that the situation is not quite comparable to the Netherlands. But one thing we do learn from our experience here is that the large importance of informal caregivers and supporting those who do take care of elderly, who do take care of people with learning disabilities or homeless people, or those, so that we, you know, if there is no professional response system, that please focus on informal caregivers to make sure that they don't get completely overburdened. I think that would be important. But I hear you, your story. I wish you strength and luck with that.
Yeah, let me just also reinforce, just to echo what Daniel said, and also to thank Joseph for being out, you know, being able to connect and work during these very difficult times that we are facing. And yes, as I just chatted, absolutely we need to include or focus on specific vulnerable groups once we are able to identify them systematically. But yes, a lot more work is needed, and we can't do it without you. And it's nice that, you know, you're able to be here. It's another example of how these findings then, according to the previous question, would go back to the government or to the people in the community who are best out there making policy, like yourself. So thank you, sir.
Yeah, thank you very much.
Thank you.
Blondine Bila, I think, was the next person who had her hand raised. Blondine?
Oui, merci. Je suis désolée. Est-ce que je peux parler en français?
Yeah. Yes, sure. She wants to know if she can, I hope I can translate you. She wants to know if she can speak in French. So go ahead, speak in French, and some of us will translate you.
Merci. J'ai une question et deux commentaires. La première, la question, c'est par rapport à David Napier et sur la vulnérabilité. Est-ce que la vulnérabilité des populations au Covid peut être liée au contexte géographique, notamment par rapport à l'exposition des pays au soleil, et également par rapport à l'évolution des saisons dans les mêmes régions. Je prends l'exemple de l'Europe. Actuellement, on voit que l'épidémie régresse. Mais est-ce que c'est parce que l'été arrive, donc le climat est plus chaud? Voilà, c'est la première question. La deuxième question, c'est par rapport toujours à cette vulnérabilité, mais est-ce que c'est lié aux conditions sanitaires? On peut rattacher aux conditions sanitaires. Je m'explique. En Afrique, par exemple, il y a un débat qui dit que c'est parce que les populations sont soumises à certains vaccins, notamment le BCG et d'autres vaccins, ou alors parce qu'ils prennent certains médicaments contre le paludisme, etc., qu'il y a l'épidémie n'arrive pas à se développer réellement. Et aussi que ça joue sur la transmission. Voilà. Est-ce qu'il a des éléments pour nous éclairer davantage par rapport à ça? Ça, c'est la question. Je continue. Le commentaire, premier commentaire, c'est pour Annie Wilkinson, qui a parlé des dimensions de la vulnérabilité dans les villes, dans les bidonvilles, dans une urbanisation informelle. Alors, elle a développé d'abord la dimension spatiale de la vulnérabilité, et ensuite, elle a développé d'autres vulnérabilités en disant des dimensions potentielles de la vulnérabilité. Et dans ces dimensions potentielles, elle a cité épidémiologique, etc. Mais moi, je pense qu'elle aurait mieux fait de présenter, j'ai identifié 5 dimensions dans ce qu'elle a présenté. La dimension spatiale, la dimension épidémiologique, la dimension liée au système de santé et une dimension systémique, en ce sens que le système de santé, c'est le pays, mais systémique, c'est la région, toute la région, voilà. Donc, c'est plutôt 4 dimensions. Est-ce qu'elle peut me dire, voilà. Maintenant, j'ai également, c'est pas une question, un commentaire pour David Kama, et il a parlé des communautés, voilà. Et je m'attendais à voir que les communautés sont organisées, par exemple, en structures comme des associations qui vont intervenir dans la riposte en tant que structure organisée. Mais dans ce qu'il a présenté, j'ai vu qu'il a parlé des populations directement. Je suis tout à fait d'accord avec tout ce qu'il a dit, mais les populations n'ont pas cette capacité d'interagir directement avec le système politique. Est-ce que aussi il peut nous parler des communautés organisées en structures comme des associations, etc. Voilà. J'ai beaucoup apprécié également la présentation de Dany Vries. J'espère que nous aurons ces présentations sur PowerPoint pour mieux nous en inspirer. Merci.
Okay, thank you for these wonderful comments, Blandine. Merci beaucoup. I will translate. So Blandine had 2 questions. The first question is to David Napier. Actually, it's a sort of double question here. David, you were talking about the vulnerability of populations to COVID, and she was wondering if, first of all, you had any information on whether that vulnerability could be related to the geographical context, particularly to exposure to sunlight or the evolution of the seasons. And relatedly, she wondered if you had any information about what she called sanitary conditions. There are debates in Africa, for instance, that people who have been vaccinated with the BCG vaccine, or those who take certain medications against malaria, the epidemic doesn't affect them as it does in other locations. So that I'm just going to put out that first question and ask David to answer it. And then there's a question for Annie and for David Mafigiri afterwards. So I'll just let you answer that, David, first.
Okay, first of all, Tamara, thank you very much. And thank you for the excellent questions. As you were asking them, I was thinking immediately of the strong need to take a health and all policies approach seriously. It's been around for a long time. What David Mafigiri just referred to as the indirect consequences of the pandemic, things like water, sanitation, mental health, so forth. We have to remember that these aren't on the radar of those developing a vaccine. And part of the challenge we face is that an exclusively medicalized approach is, at least in my view, has created a tragic set of circumstances because, let's face it, in the absence of a vaccine and outside of acute hospital care, COVID-19 is an entirely social event, which means that if we don't take those health and all policy approaches seriously, looking at housing, water, sanitation, transportation, exposure to toxic chemicals, the environment, health, communication, occupational factors, I mean, all of these things are significant. Food production, these are all significant and compounding risk factors for COVID-19, which are creating the context within which people either become more or less vulnerable. As for the environmental circumstances and those with pre-existing conditions and those who have been already vaccinated, clearly this is the consequences of the human herd and the condition of the herd as it relates to immunity have a dramatic impact on the experience of COVID-19. And it's only now that we're beginning to acknowledge the degree to which the condition of the herd actually makes people potentially more or less vulnerable. There's some very good research now that shows that being immune to one virus can actually make you more vulnerable to another one. So, so it's not as entirely a simple matter of having a vaccine or not having one. It's really about what we do together, our proximity, the environments in which we live. These have significant impacts. And I could say a whole lot more about that, but I think I should stop there given the limited time we have for this discussion. But thank you very much.
So there are a ton of questions. Okay, so next, comment for Annie. Blondine talked about the different dimensions of vulnerability that you addressed in your presentation. You talked about the spatial dimensions and others. And she was actually thinking that maybe there are really just 4 dimensions of vulnerability: spatial, epidemiological, one relating to the health system, and a 4th one that she called systemic, that is sort of really dealing with on a kind of regional scale these kinds of vulnerabilities. I'm going to move ahead to the comment that was directed to David Mafigiri. Blondine said that you talked about communities, and I think she expected to hear more about structures like associations that would actually interact with the a kind of official response. She said that she was fine with what you said, but she also felt like populations didn't have the capacity to, in effect, interact with the state, and that she was kind of wondering where the populations were. And then finally, she said that she liked Danny's presentation. So there are a few other I just want to try and get to because we only have a few minutes left. So you'll forgive me for not giving you an opportunity to respond to those. Gustavo, do you want to? Gustavo do you want to just explain your question and then we can see whether people can answer.
Okay. Thank you very much, Tamara. Thank you everyone for great presentations. So just to share a reflection and a question for all of you, probably especially to dialogue with David. So as we understand vulnerability as a dynamic, active process of vulnerabilization. It's not just a passive and a contextual counter effect. So people are not choosing to be vulnerable, but it's an active process in a kind of social, political, economic context of exclusion. When we talk about, especially about poverty and social exclusion. So we can also talk about all the other kinds of vulnerabilization, and I think that is a good topic to discuss in different settings. What we mean about vulnerability in different contexts, especially on COVID pandemic. So about this, I would like to dialogue, because here in Brazil, and I think that the most important vulnerabilization process is from the government. As you know, Brazilian government is in a terrible moment. So, but communities are organizing and locally to respond to COVID and dialogue with us. Our strategy is dialogue, and not just offer information, but how to dialogue, and their contextual settings can help us and support them. And as I'm talking about few crews to try to respond to COVID challenges, and how to project the next steps. For instance, we are 2 months, I think so, behind of Europe. Now we are in the peak of the epidemic. So how to predict, how to act, how to be prepared to the next steps, and how to support communities and dialogue with them in the next steps of the pandemic. We know that we will have to be prepared for it at least the next 6 months or 1 year. And so that's it. I would like to hear from you, your talks, and thank you very much. Over. Thank you, Tamara.
Thank you, Gustavo, and thank you for using this term vulnerabilization as a process. I think that that's a really important point to make here. Does anyone, we have a long list of people, and unfortunately we're supposed to stop at 14:30 our time. So does anyone have a response quickly to that?
Very quickly, Tamara. Yeah, I'd just like to say, Gustavo, thank you very much for talking about this, because in our work, we describe this active process as a vulnerability of spectrum, because it is a dynamic thing. It's not a rigid category. And what this means is we need new approaches. In particular, I think we need to use some of the new ways of doing research that are monopolized by people trying to sell us things online to the betterment of human well-being, because we can use that same AI technology to understand complex drivers and their dynamics. We're just not doing it. Over.
If I can quickly respond to, thank you for the question. What from the European experience, at least from the Netherlands, what's evident to us is that the whole policy is about prevention of physical impacts, and what's forgotten is quality of life. And that's a huge issue for particularly vulnerable populations who are affected at first with that. So to try to address this is to try to shift the discourse, the framing, to push back on just that isn't just about the number of deaths. It's not just about the number of deaths. It's about quality of life as well. Thank you.
Yeah, good point. Okay, so I think we have time for one more question, and then I want to just, before we take that question and before people leave this webinar, we have 2 additional webinars that are scheduled. Yes, and it's on that screen that I can't see. Yes, there's one on community engagement, which I believe will be June 15th, and a second one, which will be in French. So I think that will make everybody happy, who the French speakers on this call, and that will be on circulating ideas and their effects in Africa. So that will be on the 26th. Last question goes to Arnie, particularly because he got up really early this morning. Arnie, are you still there?
Yes, hello. I do
Great.
have some problems.
Go ahead.
I might be cutting out and in. Yes, thank you very much for this very rich discussion. I thought it was really excellent, and we very much appreciate the vulnerability tool. We are doing a little bit of work ourselves with the One Health Global Network in Canada in the area of equity particularly, and the equity impact of COVID-19. And I mean, I agree very much with much what has been said here, and I particularly share the perspective of the Dutch case study that, you know, when we talk about vulnerability, we have to be cognizant not just about the vulnerabilities of COVID and the interventions, COVID-related direct interventions in terms of the health interventions, but we also have to be cognizant of the longer term social determinants of health consequences of these direct interventions. And I think that is something that a lot of people are now waking up to, that they start to think about the implications of this and what this means in terms of going forward, how we have to readjust our policy response, and also what it means in the future if we have another wave coming up. How are we going to respond to that? To what extent are we ensuring that the most vulnerable are not necessarily even getting worse off through the lockdown? And of course, there's the case of Malami, where the High Court actually has ruled that because the government did not put adequate social protection measures in place, that the government was barred from implementing the lockdown. And so this was a very important indication of this kind of trade-off between the health intervention, but the social determinants of health consequences. And I think this will become increasingly clear and important to the discussion about vulnerability as well. So it's not just about the vulnerability in terms of the vulnerability to COVID and the direct response, but also the longer term response that we need to be aware of and assess. Over.
Does anyone want? Danny, do you want to respond to that?
Thank you. I think that's why we decided to definitely focus on longitudinal approach in this, and then we're trying to get more funding to continue the study so we can keep on following these people and try to tease out the long-term impacts. Thank you for your comments.
Tamara, David here. I just want to say very quickly that, Arne, thank you so much for this comment. But just since we are here in a group, it's helpful to realize that WHO Europe is actually working on post-COVID recovery issues, and RWJF, Robert Wood Johnson Foundation, in conjunction with WHO, is also addressing the question of just recovery. And I think that we need to be much more systematic, there was a Freudian slip, about dealing with this. Thank you very much. Over.
Okay, so we are now just about at 14:30 Paris time. I want to thank you all for joining us. This has been really just exciting to hear the presenters and to hear all of the questions. I apologize profusely to those of you who had some really excellent questions in the comments, and hope that we can in one way or another address them. I would also, in addition to the next two webinars that will take place, for those of you who haven't registered to our SonarGlobal network, so that you have access to our tools and models and curricula, you can register online, and you can also join our discussions on COVID-19. We have a discussion forum. So again, thank you all for taking the time. Thank you, many of you, for getting up at an ungodly hour to join us. We really appreciate your participation, and we hope that we'll keep interacting with you and really be able to draw all of you in. So everyone stay healthy.